Dr. Wilku, nice to see you, sir. Good morning.
Morning, sir.
Good morning. Dr. Wilku, is your screen blurred? Are you able to see it clearly?
Yes, sir. It's all clear.
Okay. Excellent, excellent. Well done, well done. You know, I said that with a specific purpose. When I get up in the mornings, I have difficulty reading. And very often, if I'm not wearing my spectacles, the screen is blurred and I'm just not able to see clearly. And I have to tell you that more than 40% of our diabetic colleagues have problems relating to the eye. And when I was reviewing our subject, I discovered that a stupendous 67% of the global population wears spectacles. We certainly cannot do without our ophthalmologists. We certainly cannot do without our ophthalmologists. Well, I'm going to welcome Dr. Brahim by saying, bonjour, monsieur.
Bonjour.
No, that is as far as I can go in French, Dr. Brahim. That is as far as I can go in French. I learned it up specifically to say hello to you, because I noticed that in your very lovely profile, you speak French, and that you spent time in Algeria, and that you studied in the University of France. So I thought it only appropriate that I should talk to you in a language that makes you comfortable and feel at home. But my request, sir, is that you should, if you don't mind, talk to us in English, which is the language that we in UAE tend to revert to when we are not talking Arabic. Okay. Ladies and gentlemen, that was a brief exchange of friendliness between Dr. Brahim and Dr. Wilku and myself. Good morning and welcome. Good morning on the 17th of October. It's a very special day for me. It is my granddaughter's birthday. So this is a special day for me. But good morning to all of you and welcome to our DiaBeat webinar. Our topic is diabetes and eye care. And as I mentioned to you, 60% of our world's population wears spectacles or has some form of difficulty. And if you have diabetes, your probability of eye ailments escalates to almost double, which means almost 40 to 50% of our colleagues who have diabetes have some form of eye complication. And I notice words like cataract, which I understand, and then I've read about glaucoma and retinopathy, macular edema. All these words are French to me. So I will leave this now to my colleague, Dr. Brahim, to talk about. But before that, Dr. Brahim did his studies in Algiers in the University of France. I'm not quite sure whether I have the details correct, but I do know that Dr. Brahim also spent time in the University of France, or spent time in Algeria. Now, in Algiers, which of course reminds me that the next time I see Dr. Brahim having lunch in our cafeteria in the hospital, I'm going to sit down with him and have a nice friendly chat. But Dr. Brahim has a more serious side to his life. He is our ophthalmologist. He's a specialist in ophthalmology with our own RAC hospitals. He manages vitreoretinal complications of cataract surgery, retinal detachment, macular pathologies, intraocular foreign bodies, ocular infections, inflammation, trauma, et al. I've used these words, friends, and I have to tell you, it will be enlightening for me to try and understand from Dr. Brahim what these ailments are. I am simply grateful that at this point of time in my life, I am just wearing spectacles. Thank you so much, sir. And the floor is yours. Thank you so much, Dr. Brahim.
Thank you, Professor. Thank you so much. First of all, I would like to thank you and thank Dr. Wilco, and of course, thank all the audience who are here with us to talk about a very important subject. And of course, I would like to thank the hospital to giving me this opportunity to speak about this important topic. So, if we talk about diabetes and eye, you have to know that the most important part of the eye, which is the retina, it can be affected by the diabetes. But of course, we can have more and other complications like recurrent infection, conjunctivitis, or recurrent chalazion, or cataract, early cataract. Cataract usually started after 6 years old, but if you have diabetes, we have a chance to have it before 50 or before 45 years old. But as you know, the cornea, if we have problem with cornea, we can replace it. We can replace the lens if we have cataract, but the retina, we cannot replace it. So it's the most important part of our eyes. So the objectives of our lecture today is to know or to recognize the importance of diabetic retinopathy as a public health problem. Secondly, to discuss diabetic retinopathy as a leading cause of blindness in developed and developing countries. Third, identify the risk factors for diabetic retinopathy. Describe and distinguish between the stages of diabetic retinopathy. Understand very important role to risk factors, control, and annual dilated eye exam by ophthalmologists. So, as you know, diabetes is a group of disease characterized by high blood glucose levels. And we have two types, type 1 and type 2. Type 1 is usually, we can find it in children and young adults, and it represents 5%, only 5% of diabetes. And because we don't have, we cannot produce insulin. The second one is the most common form is type 2. And in this type, we have insulin, but we don't have enough insulin, or we ignore the insulin or resist to this insulin. So what about diabetic retinopathy? Diabetic retinopathy definition is like it's dysfunction of retinal blood vessels caused by chronic hyperglycemia. So it can be it can be complications of type 1 or type 2 of diabetes. And the most important thing to know that the first stages of this diabetic retinopathy is asymptomatic. There's no symptoms. And if we don't treat, we don't act on that time, we can have a low vision and blindness. So what's the retina? As I said, the retina is the most important part of our eye. It's lying behind in the back of the eye. It's multi-layered light sensitive neural tissue. It's part of our brain in our eye. So it's a brain in our eyes. And from the retina can focus the light and transmit it through the optic nerve to the brain, and we can see. So the retina is very important, and we cannot replace the retina. There is part of in the retina, I should talk about it, is the macula. The macula is the center of the retina. It's the most important part of the retina. And with the macula, we can see sharp vision, we can recognize faces, we can read. So it's the most important part of the retina. We call it the macula. And it's important to know this because we will discuss later about the macular edema. So here you can see two images of the retina. Okay, the left one in your side, it's healthy retina. We can see that we have optic nerve in the center, and from the optic nerve, this white dot, we have from here we have emerging of vessels. This is all your retina, and the center, this is the macula. This is a healthy retina, but you can see clearly that In the other side, the diabetic retinopathy, we can see that it's not normal. We can see there's more red here, it's hemorrhage, or yellow, it is exudation. We will discuss about this later. So diabetic retinopathy as leading cause of blindness in the world. You have to know that the first cause of blindness in the world still the cataract. It represents 40% of the blindness. But cataracts, as you know, it's very easy to do surgery and we can have very good vision. But unfortunately, some places in the world, they don't have access to the care, so still a cataract-like problem there. The second cause of blindness is uncorrected refractive errors like myopia, high myopia. The third one is the glaucoma. Glaucoma is very important to know. And if we have opportunity, we can discuss later about this, and we can do term about glaucoma, which is the first cause of blindness in the developing countries. On the other side, you have the AMD, age-related macular degeneration, which is the first cause of blindness in the developed countries. It's because of the aging. We have also the corneal opacities and diabetic retinopathy, which represent 4% of leading causes of blindness around the world. So let's talk about epidemiology. According to the International Diabetes Federation, in 2024, there is 589 million people having diabetes. And in our region, in MENA region, in Middle East and North Africa, there's 85 million people with diabetes. And in 2050, it will be 163 million patients. What about UAE? We have 20.7% prevalence of diabetes. In other, this more than 1,200,000 cases of diabetes. In 2020, we know that we have done more than 1 million people having blindness because of diabetic retinopathy, and more than 3 million with MSVI, does mean moderate to severe vision impairment. So the highest percentage of diabetic retinopathy, blindness, and MSVI, I mean moderate or severe vision impairment, we found it in Latin America with 6.9%, and MENA region, North Africa and Middle East, with more than 2% of the blindness. So the best predictor of diabetic retinopathy is the duration of diabetes. And we know that after 20 years of diabetes, we can have more than nearly 99% of diabetic type 1 and almost 60% of diabetic type 2 having a degree of diabetic retinopathy. And you have to know that people with diabetes has unlikely 25 times more than the normal generation to have blindness. So very important to know the risk for blindness with diabetes. And the problem that diabetic retinopathy happens in the people of working age does mean that it's a big burden for the economy and the insurance. Here, this studies, it's old, but it's shown that when we do intensive control of diabetic retinopathy, we can reduce the diabetic retinopathy or more than 76%, and we can slow progression of existed diabetic retinopathy by 54%. The same control, intense control, we can reduce the risk of clinical neuropathy and by 60% and by 54% of kidney problems. So what are the risk factors? As you know, the first important factor is the duration. I mean, with time, we can have risk. We have risk for diabetic retinopathy. This is the first thing. Second one is the poor blood sugar control. If our diabetes is not controlled, we have more risk to have diabetic retinopathy. And also, if we have hypertension and hyperlipidemia, and we cannot access to care, these all are risks for diabetic retinopathy. So the most two factors I can say, the first one is duration, but in this factor we cannot act. It's duration, it's chronicity of diabetic retinopathy. But second one, which is sort of the severity of hyperglycemia, in that we can act, we can do something to stop and to prevent diabetic retinopathy. So if you have diabetes, how should you see doctor, I mean ophthalmologist? So if it's type 1, you can wait 3 to 5 years after be diagnosed by diabetic retinopathy type 1 and see doctor, because type 1, we can know exactly the date of happening of diabetic retinopathy. But if you have type 2, at the time of diagnosis, you have to see doctor, ophthalmologist, and to check for your retina, because we cannot know if it's new, really new, or old diabetes. So we have to check for our retina. What about the women? If prior pregnancy, very important to control your eyes before conception, because before planning having a baby, I can say. And depending of diabetic retinopathy, you can do a control monthly or after 3 months. So what are the symptoms of diabetic retinopathy? The most, I can say, important message you should take, that the first stages, it's asymptomatic. We don't have symptoms. We can have very good vision, 10 out of 10 or 6 out of 6, but we have diabetic retinopathy. Because if the macula is not, it's not included by the diabetic retinopathy, you can have very good vision. So very important to check for it, for your eyes, even you don't have any symptoms, but you have diabetes. Other symptoms, of course, it's like blurred vision, like start to have blurry or floaters. That means we can see floaters or shape inside our eye. We have to see doctor. Fluctuating vision, very important. Professor Kidney, you said morning we have like, it's not good, at with time it start to be clear. Maybe because of the macular edema. If we have macular edema, usually we have like bad vision in the morning, and with time this edema can decrease, and we can have better vision. So fluctuating vision, it's symptom of diabetic retinopathy. Distorted vision, when you are reading something and you see that it's distorted, the vision, if reading something, it's not clear and it's distorted. The shape are not normal. The letters are bigger than the normal or smaller than normal. So it's a very important symptom of diabetic retinopathy. If you have dark area in your vision, does mean that there is something inside, maybe blood inside your eye, you have to see a doctor. If you have poor night vision, it's very important to check for your retina. Or if you have partial or total loss of vision, this is the ultimate stage, does mean that you have like retina detachment or intravitreal hemorrhage. So here we have classification of diabetic retinopathy. I will not tell you about the details, but you have to know something, that you have 2 major stages. The first one is before it, we call it proliferative stages, and the second one, proliferative diabetic retinopathy. When we say proliferative diabetic retinopathy, this means we have new vessels in our retina, and this is alarming. This is emergency. You have to see, we have to act. We have to do laser or surgery or an injection. We'll tell you about this. Before that, before proliferative diabetic retinopathy, we have non-proliferative diabetic retinopathy. It can be mild, moderate, or severe, and doctor can, our ophthalmologist can tell you which stages, and depending on the stage, he will plan the treatment. Here, just a normal retina. As I said before, you have here the optic nerve, the head of the optic nerve. From that, here you have the emergency of, vessels from here, vein and arteries, and this is the macula. This is normal retina. When you have mild non-proliferative diabetic retinopathy, you have, if you can see here, small dot, a red dot, it's microaneurysm, and because of dilation of vessels. This is really the earliest stages of diabetic retinopathy. And in this stage, patient can have very good vision. Moderate non-proliferative diabetic retinopathy, you have more microaneurysms. We have hard exudation, that means fat in the retina, and we have flame-shaped hemorrhage starting here. A stage later is severe non-proliferative diabetic retinopathy. It's still non-proliferative but severe. We have more hemorrhage and we have venous bleeding here. The other part is the proliferative diabetic retinopathy. Here we can see that, of course, we have this hard exudation, we have hemorrhage, and we have new vessels here. This is the new vessels. What's the thing with the new vessels? New vessels are very dangerous for the eye. They are not normal vessels. The new vessels are weak and can break at any moment. And when they break, we have hemorrhage inside our eye. We call it intravitreal hemorrhage. And if it's not treated, this hemorrhage will tract the retina, and we have a retinal detachment. And this is very bad to have these stages. So what about the macula? As I said, the macula is the most important part of the retina. So diabetic retinopathy stages, non-proliferative, proliferative. Macula, we can have edema in the macula. And when we have edema in the macula, as I said, it's the most important part. And with it, we can see sharply, we can read. If we have edema, we cannot read. It starts to be blurred. And the diabetic macular edema can present at any stage of diabetic retinopathy, non-proliferative or proliferative, but there is more common in patients with proliferative diabetic retinopathy. Here, same thing, two images. First one, normal retina, and second one, macular edema. This is the macula, the right, which is normal. Here I can see that the macula is not normal. We have yellow dots, exudation, and it's not normal. But we cannot be sure is it macular edema or not. For that, you have to do something, we call it OCT. That means OCT does mean ocular coherence tomography, like scanner of the macula. Here, the macula, which is normal, we can see the OCT is normal with normal depression, and all the layers of our macula are normal. But here, with macular edema, we have, with the diabetic patient, we have edema in the macula, and we lost this normal depression, and we have fluid inside the macula. In these stages, of course, patient has very bad, or very poor vision. So prevention. 90% of diabetic eyes disease can be prevented simply by proper regular examination, treatment, and by controlling blood sugar. Very important. And we can say that we have primary prevention, secondary prevention, and tertiary prevention. Primary prevention is strict glycemic control and blood pressure control. Secondary, we have to see your doctor, your ophthalmologist, and do your eye examination, dilated eye examination. Tertiary prevention, if we have something, we have to act. We have to act as by what? By laser, we call it a PRN, laser photocoagulation, or vitrectomy. Vitrectomy does mean surgery inside the eye. So the best measure of prevention of loss of vision from diabetic retinopathy is strict glycemic control. Here, just I will talk to you about laser photocoagulation. So laser, it's not surgery. We can do it here in our OPD, I mean, in outpatient clinic. We have to dilate the patient. If we have proliferative diabetic retinopathy, we have to do laser. Does mean we have to do laser all over the periphery and the retina and prevent this part, which is the macula, the most important part. Doing this laser, I can say, kill these new vessels and prevent our eyes from intravitreal hemorrhage and more complications. We can do also laser if we have macular edema, but very rare patients, we can do laser for the macula. What about the injection? I think you have heard about injection and intravitreal injections. So injection does mean it's product, it's anti-VEGF, anti-growth factor. We inject inside the eye to reduce the new vessels and to reduce the edema. These injections, we do them of course in the OT, not in the outpatient. And there is a regimen for this. For example, if you have macular edema, we inject every month, one injection, 3 to 5 months. After the 3rd or the 5th month, we do our OCT and we see if the macula is normal, I mean the edema is reduced or no. If it's reduced, that's done. So we can just follow up without injection. And we can do also injection if you have proliferative diabetic retinopathy. What about the surgery? The surgery, yes, it's the intermediate stages of diabetic retinopathy. If you have blood inside the vitreous, or we have already retinal detachment, we can do something. We can do surgery. We can remove the blood inside, and we can repair the retina if it's detached. So my conclusion is like diabetic retinopathy is preventable through strict glycemic control annual, dilated examination by ophthalmologist. Thank you so much.
Thank you, Dr. Brahim. Thank you. That was very interesting and certainly gave us a lot of information. Now, before I hand over to Dr. Wilku, I have to ask you a few questions. You know, one thing is clear, Doc, that from your state, from your various slides, I have diagnosed, or I have come to the conclusion that I definitely have diabetic retinopathy. And the reason is blurred vision, poor night vision. I was driving last night in my own car, and I was driving, and I'm quite sure I had a lot of difficulty. So that is good information. The second bit that I needed to touch upon was that you mentioned, and you have to forgive my ignorance, that laser is not surgery. And you were talking about laser photocoagulation. That was one. And the other thing, the other slide that came soon after was the injection in the eye. Yes. I have to ask you, Doc, is it painful?
No. The laser is not painful. We do it under local anesthesia. We put like only topical anesthesia, and we put contact lens with the cornea. Of course, after dilation, we start to do laser. It's not painful. I have to tell you that you have to do 3 to 4 sessions for each eye. So when we start to do laser, it's not painful.
Excellent. And
sorry, the injection, same thing. It's not painful, but this injects because it's inside the eye. We cannot do it in our OPD. We have to do it in the operating theater, and it's not painful.
Excellent. Thank you, Doc, and thank you for all those very lovely, fascinating slides of the retina. And I love the way you presented the retina by saying that it is part of the brain in the eye.
Yeah.
That was a fascinating statement that you made.
Yes.
That was a fascinating statement. Thank you so much, Doc. I will now leave you in the capable hands of Dr. Wilku for various questions. Dr. Wilku, sir.
Thank you, Professor Kennedy. Thank you, Dr. Ibrahim, for a wonderful session and putting up forward in a simple way so that everyone can understand what are the things and what we should be caring of. So that's the reason I see a few questions. I have many questions in my email also, but I will start with the chat box. Okay. Jinsi has asked, my father is diagnosed of retinal detachment with proliferative retinopathy and was suggested for laser surgery. Is laser treatment safe? Just like Professor was also worried about.
Yeah, it's safe, but you have to know that if we have retinal detachment, laser, it's not enough. In that case, we have to act. We have to do something. We call it vitrectomy. It's surgery. We remove the vitreous. We remove the traction because there is traction pulling up of the retina. So remove the vitreous. We flatten the retina and we do the laser in the same time of the surgery. So in the same time of the surgery, we finish with the traction, we finish with the retinal attachment, and we do the laser in the same time. After that, we put tamponade, like silicone oil, to keep retina flattened, which should be removed after few months, 3 to 6 months.
Yeah, good. Second question comes from Ram Basnet. He's also having similar problem which professor was also mentioning about yesterday's while driving. He suffers occasionally from blurred vision. That is since after getting COVID, like floaters and sparks, which you are also mentioning about, when he moves his head sideways. I have been diagnosed as pre-diabetic. Is this serious?
No, if it's pre-diabetes and it's controlled, the retina should be normal. Usually diabetic retinopathy, we have few years of diabetic, and when it's not controlled. So I can understand that pre-diabetic is not diabetes, so it's controlled, I can say. So maybe it's not diabetic retinopathy, maybe other thing, maybe starting of cataract, if depending of the age, or only dryness, or just glasses, spectacles.
Yeah, and what about the floaters and sparks if
Yeah,
is
yeah.
feeling while moving the head sideways?
Yes, so we can have floaters and we are not diabetic, sorry. So floater doesn't mean that vitreous problem. Floater doesn't mean that there is, we call it PVD, I mean posterior vitreal detachment. So the vitreal floaters, when you have floaters, very important to check. Very important to check with the doctor. The doctor will do same thing. Check your retina, because floaters, if you have floaters, that means you have traction in the retina, and we can find like retinal bricks or holes, especially if we see sparks or photophobia. We call it photophobia. In that time, it's not diabetes. We have to do laser in the retina in these holes or bricks to avoid another kind of a retinal detachment. It's not the same as for diabetic patient.
Yeah, I think it's better to get a consultation and check it properly, so
Yes.
that we should not neglect any undue coming thing. Okay. Poco has asked, I have diabetes and high blood pressure, for which I take medicines. My glucose levels are good, but I have fluctuating blood pressure. Is it a risk for retina problem?
Of course. It depends of how long you have diabetes. If it's type 2, you should see doctor. You should check for your retina. As I said, the earliest stages of the diabetic retinopathy, it's asymptomatic. There's no symptoms. We can have blood, we can have diabetic retinopathy, and we have very good vision. And if we not act in that time, in that case, we can have problems later.
Yeah, that was good. And Suzanne has mentioned that she had a laser treatment 2 years back in Kerala, and she didn't go for a follow up. Is it okay or not? I think you should be doing a follow up with
Yes.
this. Okay. And 1 second, I'll be having another questions with that. Okay. There is one more question. One second. One participant is posting, but he's not able to post it. I will take his question. Ah, Satnam is asking, he has frequent itchy eyes and redness. I don't have any other medical issues. Mostly I'm prescribed anti-allergics. What do you suggest? How to manage it?
I have to see you before. I don't know what exactly. It could be like dryness or conjunctivitis, allergic conjunctivitis, but yeah.
Yeah, okay. And Sarfraj has asked, his father has diabetes and recently is diagnosed with glaucoma. Will it affect his vision?
Yes. So you have to know both diabetes and glaucoma are factors of blindness. So very important to check to control our glaucoma and diabetes. The glaucoma is very important to screen for glaucoma after 40 years old. Even if we don't have any problems, we have to screen for it. Especially if we have someone in our family with glaucoma, we have to do it before 40 years old. Glaucoma, same thing like diabetes. It's asymptomatic in the first stages. So if we see patient at the good time and we put drops, we put the treatment, we avoid the blindness after 15 or 20 years later. But if patients comes at 6 years old and optic nerve is already gone, it's white, it's too late. Of course, we have to control glaucoma with drops or with laser or with surgery, and at the same time control diabetes, so to avoid diabetic retinopathy.
Yeah, that was a nice suggestion. Doc, I think we have covered almost whatever questions I have. So all are similar questions, but I will ask some rather a question. What should we look for if we are diabetic on medication? And what are the sign symptoms? First sign symptoms we should be careful about eye, and we should consult the ophthalmologist.
Okay, so my very important message, take-home message, is to see doctor even if you have very good vision. You have diabetes, you have to check for your retina. Okay. After that, if you have diabetes and you see that there is floaters inside your eyes, or your vision is not good in the morning, after that it's coming better, or you see like it's blurred, of course you have to see doctor, because it could be like diabetic retinopathy or macular edema or other complications. So if you have diabetes, most important thing is to control your sugar, very important, control the HbA1c, control your hypertension if you have blood pressure, and see a doctor, eye doctors, to see or to check for your retina, to do dilation and see your retina. And if you need some other test like OCT, with the OCT. So that's my home message.
Yeah, I think that was. I was actually going to ask the second part, and you have already said the second part of my question. Okay, again, in one line, what will be your takeaway message for all for eye care, whether they are diabetic, non-diabetic, just simple for eye care?
Okay, for our eyes, of course, first of all, avoid screens, too much screens, phones, gadgets, not good. Secondly, eat healthy, because of course there is something which is not good for the retina. Eat more omega-3. Third, if you have any problem in your vision, don't wait, see a doctor. And if you have more than 40 years old, screen for the glaucoma. If you have kids with 5 or 6 years old with for you good vision, we have to check for the eyes, because we can have lazy eye, and the kid we will not say that we cannot see. So at 6 years old, we have to check for revision.
Yeah, I think that was a best takeaway message I can also pass on to my kids, because everyone nowadays are more spending their time on screen or all
Yeah,
gadgets. But
yeah,
unfortunately, studies are also like that. Students have to focus more on iPads, laptops, and other things.
yeah,
Okay,
yeah.
that was a good suggestion. I will pass it on. Thank you very much, Dr. Brahim.
You are welcome.
I think I have covered my questions. Professor, over to you.
Yes, I add my thank you to Dr. Brahim. You know, he was able to help me to see my eye problems more clearly just
Thank
by
you.
simply talking about it. That was absolutely lovely. But I can assure you that as popular as Dr. Brahim is with me, I agree with you, Dr. Wilku. He is going to be extremely unpopular with my grandchildren who are perpetually on their screens. I have to find a way. I'm going to show them this video and tell them the good doctor says that you should not be looking at your screens.
Yes.
Dr. Brahim, thank you so much, sir. I'm going to get in touch with you for sure. I am
Thank
going to
you
get
so
in
much.
touch with you for sure. Thank you so much.
Thank you,
My
Professor. And happy
Thank
birthday
you,
to
sir.
your baby.
Thank you. Yes, I will do. I'll definitely convey that to her. And our audience, thank you so much. You know, these webinars are so informative. It is unbelievably informative. Every webinar we have so much of vital information. You know, if at all they had an Oscar for webinars. I believe it is the DiaBeat webinar and the weight loss challenge webinars that will get the Oscars. These are truly very valuable webinars. And thank you so much for that, Dr. Brahim. Audience, thank you so much. I have to thank our backup team that never comes on screen. I think one day we are going to put them all on screen. We have Sadeh Saloni, our IT team, all sitting behind their systems and making sure that we have an error-free presentation. And this goes on week after week. And I can see that in our next webinar is on the screen, and that is, I have it here. At my age, we also read papers and things like this. So I have it right here in front of me, Friday, 24th October. The topic, kidneys at risk. And the speaker, Dr. See, again, Dr. Brahim, here I am. This is in such small print, I can barely read it. Dr. Anjanikia Patel. I have to come and see you, doctor. Otherwise, my vision, my eye vision, and perhaps my vision for my company also will benefit from your advice. Thank you so much, friends, and have a great day. Thank you so much.
Thank you so much. Thank you, Professor. Thank you. Thank you all.